Good afternoon, everybody, and welcome to the webinar, New Technology to Improve Wellness in Indian Country. This is Jennifer Spiegler from Kognito, and I am very, very pleased to have Jami and Glenn on the line to talk about their work and introduce themselves. Before we really get started, and while people are still logging on, in addition to thanking you for taking time out of your day to join us, and thank you so much for doing that. I know that everybody is really busy always, so thank you for coming. I do want to say that we will be recording the webinar. We will circulate the slides along with a link to the recording so that you can share both of those with folks that you work with. And that will also have the links to access all of the free resources that we're going to be talking about today. So without further ado, I'm going to let Jami introduce herself.
Hi, good morning. You there, Jami? Yeah, good morning, everyone. My name is Jami Bartgis. I'm the president and CEO of One Fire Associates, an organization that works to build evaluation capacity for tribes and urban Indian communities. I'm very excited to be here today to be able to talk about these great resources that are freely available to Indian country. We've been, Dr. Albright, Glenn Albright and I have been working together, I guess for about 6 years now, to try to find ways to bring these simulations to tribal communities. You're really going to be in for a treat to see what some of the technology can do. And then we're also going to talk a little bit about some of the research that we've done for use with tribal populations, as well as a recent pilot test that occurred within a tribal school system. So we're excited to bring that information to you all. So I'm happy that you all are on the call, and I'll turn it over to Glenn.
Hi, everyone. My name is Glenn Albright, and I'm co-founder and director of research here at Kognito. And coincidentally, I'm also an associate professor at Baruch College, which is one of the senior colleges of the City University of New York. And I'm very happy to be here to talk with you and to answer any questions that you may have.
Okay, I'm going to cover, sorry, this is Jennifer. I'm going to cover just the agenda so you know what the flow is going to look like here. We're going to talk very briefly. I'm sure people have on their minds, what is a health simulation? What is this new technology they're going to be talking about? We'll give you a little, I think, brief introduction to that. And then we're going to do a quick demonstration just so you understand and have that as context for Jami and Glenn talking about the research findings. They're going to be talking about their peer-reviewed study, and then Jami's going to talk about the pilot she did within a rural community. I'm sorry, those two bullets under the research findings should be indented, and somehow this slide was not cooperating. After they talk about the research, we will look at some simulations that are already available at no cost across Indian country, and hope that you'll think about accessing those in your communities. We'll talk about some other simulations that are available at subscription costs that might be relevant to work that you're doing, and we'll talk about what it looks like to adapt a Kognito simulation for your own purposes. And then we'll take Q&A. So you have a dialog box on the right-hand side of your screen that says questions. If you have questions, please feel free to type those in. If you want to just see what it feels like to use that dialog box now, please just say hi and let us know where you're from. I'm going to hand it over to Glenn to tell you what a health simulation for health actually is.
Okay. Well, as you might have guessed, Kognito is a health simulation company, and we're based right here in New York City. And we create role-play simulations for the purpose of really providing users with the ability to lead real-life conversations in the areas of health and behavioral health. Now, this is accomplished by placing users in a virtual environment where they can talk to emotionally responsive virtual humans that have personality, they have memory, and it's in practicing these conversations that one is able to build the skill and the confidence to have them in real life to be able to improve health. Now, we have a strong belief that conversations are a very powerful tool to bring about change, and many of the conversations that you'll be seeing today are indeed ones that have been shown to improve health and bring about change. So often we are asked, why virtual humans? And there's a whole bunch of reasons for the use of virtual humans, and perhaps the most profound one is that people find them more comfortable to talk to. They find it easier to open up to them, to reveal what they're thinking and feeling, not worried about being judged. So the learning experience is really improved because of this level of comfort. Also, virtual humans can speak multiple languages. They have different personality, different appearances, and it's in interacting with them that you're really able to gain the skill and the confidence to manage health conversations in real life. Now, there's other benefits you can see there. Certainly, we'll send the slides to you and you can go over them.
Great, thank you, Glenn. We're going to take a quick look at what this technology actually does and what it looks like for the user, just so you can understand how this works. And let me start out by saying this what you see on the screen is a screenshot from what's actually the actual simulation. At Risk for High School Educators is an evidence-based program listed in SAMHSA's National Registry of Evidence-Based Programs and Practices. It's been used by tens of thousands of teachers across the country, including some that are American Indian and Alaskan Natives. And I'm going to show you the interactive conversation that Glenn was just talking about. On the screen you see Jackie Torres, who's your virtual coach. And we use Jackie in this case to provide some didactic content for the learner and prep them for what they're going to experience. So I'm going to let Jackie introduce herself and introduce the simulation to you. You might have a little bit of a sound sync delay because we're using this GoToMeeting software. That's not something that usually happens when you do this directly. It is intended, though, to be an individualized experience where you are, as an individual, interacting with the simulation. So here's Jackie.
Hi, I'm Jackie Torres. I'll be your trainer today as you take this program to gain greater skills in identifying, approaching, and referring students who are at risk for psychological distress. Now, what does that mean, psychological distress? Well, it could just mean a student is going through a rough time, that things at home or in their social life are causing them pain. Or it could mean the student is starting to show signs of a mental disorder, like anxiety, depression, disruptive disorders, and substance abuse. I know you're an educator, not a counselor or a psychologist. I don't expect you to diagnose students or help them work through their issues. What we will talk about today is how to notice worrisome behavior, talk to students about it, and connect them with your school counselor. Because let's face it, you're on the front lines. You and teachers like you know our students better than anyone else. So you're in a great position to connect students who need attention with a counselor who is here to give that attention. Now, before we go any further, I want to tell you who I am.
Great.
How I'm
So let's stop Jackie right there. Yeah, there you go. So that's the didactic, how the didactic portion of this rolls out. And after Jackie educates you and introduces you to a number of different characters, this happens to be a simulation that runs for about 60 minutes, has 3 conversations, and this is what it looks like when you get into a conversation. You, as the learner, take on the role of Sean Lyons. Mr. Lyons is an English teacher with about 10 years of experience, and you will have met him through Jackie earlier in this experience. And he's talking to his student, Renee, who is a junior, high-performing student. And what we've learned in going through Renee's profile is that she's very, very anxious. She is looking for affirmation from teachers all the time through texts and emails all times of day and night. And we have heard a rumor that she might be cutting herself. Now, Renee, as you see, is as Glenn mentioned, she's an emotionally responsive virtual human. So she is coded to remember what you said, to have her own personality, and to respond like a student would in real life. And the way you interact with her is through these dialogue choices. You see that you have different topics. You can make small talk or express your concern, and you have different ways of doing that. You could ask her about the track meet or about her family. We know from having looked at her profile, or you would have known from looking at her profile, a little bit about her. Or because you're rushed and you're short of time, you might just jump right into expressing your concern. You might have two different ways of asking her. These are two different kinds of tactics. This is, I've been concerned about you lately. You seem stressed, or you seem really nervous lately. So let's pick one and see how Renee responds.
You seem really nervous lately.
No, I don't. I mean, what are you talking about?
Okay, and now you see a couple things. You notice that Renee got slightly defensive. Her voice, her body language, and her face all showed that. You notice that your choices have now changed. Over here on the left side, you have new topics that you can broach with her. And you also have the opportunity to undo your choice and try something else. You'll also notice that you have some advice from your virtual coach. And she pops up and says, this is a broad criticism that's likely to make her defensive. A better approach is to gently express concern about specific behaviors. Now again, Renee is an emotionally responsive virtual human. So if we undo that choice and try a different choice, watch the difference in Renee's reaction.
I've been concerned about you lately. You seem a little stressed.
Oh, I don't know, maybe. Why?
Okay, and you get a different type of advice from Jackie. Now Jackie is giving you not corrective feedback, but praise for your choice, explaining why that was a good decision and indicating how you might proceed. So that's all I'm going to show today. I think it gives you enough of an understanding and context for what Glenn and Jami are going to discuss about their research. So let me hand it back to Glenn, and here you go.
Okay, this is a study that Jami and I conducted on an AI-AM population that took one of several of our at-risk simulations, and it was recently published in the Journal for the American Indian Alaska Native Mental Health Research. Next slide, please. So at a total of a total number of people who took the university and college faculty at-risk training, the college student training, high school educators, and middle school educators, all listed on the right side of the PowerPoint. Of all the people who completed that training, we identified 983 AI-AM students and educators. Of those 983, there were 86 matched pairs. A matched pair are individuals who took the pre-survey, then right after completing the simulation, a post-simulation survey, and then a three-month follow-up. So you can see the sample size there, 9 from middle and high schools, 42 from colleges, and 19 from states. And a repeated measures ANOVA was conducted to look at the results. Next slide. So we had a pre-training survey that included the gatekeeper behavior scale. This is a 11-item scale that's based on attitudes towards gatekeeper behaving and suicide prevention. It measures how prepared individuals are to identify those in distress, to approach them, to talk to them, to manage that conversation, and to motivate them to seek help. So we have a preparedness item, and then a likelihood item, which is behavioral intent. So once you've identified someone, how likely are you to actually approach them and talk to them? And then lastly, a self-efficacy or self-confidence items in which, how confident are you in talking with a student? How confident are you in discussing suicide for a student who's at risk? So this gatekeeper behavior scale was measured at all 3 time points, pre, post, and at the 3-month follow-up, along with self-reported helping behaviors. Now, these helping behaviors included 3 things. That is the number of students you have identified in psychological distress, the number of students you approached to talk to, and lastly, the number of students that you referred. Next slide, please. Okay, if you go back, this is just the gatekeeper behavior scale. It's in the slides. You're free to use it in any way that you find that will be helpful. Next slide. So we see the demographics here in terms of the number of faculty, staff, students, high school educators, and middle school educators, and the different races or ethnicities. Next slide. More on the demographics, including gender, age, and so on. Next slide. Now, means efficacy is an examination of the user's perception of how effective the training tool is. And the more effective they think the simulation is, the more likely it is to actually change behavior. And one of the things that we see here is that it has very high means efficacy, which nicely predicts future behavior changes. Next slide. And Jami, do you want to talk about this, or do you want me to continue on?
Oh, yeah, you can go ahead and I'll talk about the pilot.
Great, thanks. So here, in terms of the gatekeeper behavior scale, we have a composite variable that shows an increase, significant increase from pre the follow-up in preparedness to engage in gatekeeper skills, the likelihood or behavioral intent, and self-efficacy. So we see a change that is significant from pre to follow-up that's coincided with a significant increase in the composite behavior score. That is, from pre to follow-up, the number of students that were identified, talked to, and referred. So there are numerous advantages to this type of simulation. Everything from being able to involve in the learning experience in the privacy of your own home. There's a minimal or no risk of being judged or feeling embarrassed because you're not doing face-to-face role plays where people are watching you. And of course, it's very sustainable. The reasons you can read are to the left, and there is some limitations to this study in that there was no control group and that you're basing the evidence on self-reported behaviors as opposed to looking at the actual number of people who showed up at mental health services. And we did use people who selected to complete the evaluation, and so there might be some bias there. And of course, like all researchers, we would love to have an increase of sample size and a simulation that is like really more culturally adapted to the community. So Jami, take it away.
Yeah, so one of the things we really recognized and really was a limitation of the study is that this was taken from American Indian users in settings across the country. And so we didn't really understand yet what would it look like if you tried to actually implement it, particularly in a remote or rural tribal community. So we had the opportunity to do a pilot with a tribe in the Great Plains area, and we worked with them over several months to, get a plan about how they would be able to implement it within a tribal high school. That simulation or that pilot project was quite successful. The tribe that implemented these simulations liked it so much that they've already repeated it in the second academic year. And we were able to go ahead and get some preliminary data from that pilot that was very much in line with what Glenn has already talked about in the overall paper. So we did see for those in the tribal school, and these are high school educators, so that was the simulation that we piloted. And what we found was that teachers identified increases post-training on knowing when to recognize that a student's behavior might be a sign of distress. They also showed improvements in their feelings, like their ability to discuss the concerns that they have with those students, as well as increases in their belief that they could motivate a student to seek help. And then interestingly, which again is consistent, almost 90%, it was just slightly under 90% of individuals who took, and these are tribal high school teachers and educators that took the simulation, said that they would recommend the course to their colleagues, and 100% that took the course rated it as either good, very good, or excellent. So of that, 52% said it was very good, 32% said it was excellent, and then 16% said it was just good. So we had 0% that reported it was a poor simulation. We even had some qualitative responses for that, where people, some of the people who were taking the simulations from the tribal pilot said that the students' issues were very similar to those that they dealt with on almost a daily basis. Another individual said that it really gave different students in crisis, gave them good examples for how to relate to the students in their own school, and how the information was very valuable for them. So we were very excited to know that when we were able to pilot it in a rural, remote community, it still was able to work, and it was similar to what we found in the data results for the publication. I'll turn it over to Glenn now.
Next slide.
Well, Glenn is going to graciously turn this over to Jennifer, and thank you, Jami, for that nice explanation.
Sorry.
That's okay. So what we do want to talk about and make sure that everybody understands on the phone that there are health simulations like some of the ones in Jami and Glenn's study. The one that Jami just mentioned that was piloted in a rural community. Some of these are available to Native American and Alaska Native tribes and urban Indian communities for free right now through the sponsorship of various entities. Some of them are available for subscription, that would be as a paid subscription from Kognito, and we want to just mention what would be possible in terms of adaptations for the future. So let me talk a little bit about what's available for free right now in Indian country, and again, we will be circulating these so you don't have to try to capture this. And actually, in this slide, the names of the simulations are all links to actually go either to the simulation or their launch page for you to access them. One is called Calm Parents, Healthy Kids. It was developed with Robert Wood Johnson, and it's around managing challenging behavior for 2 to 5-year-olds. So this is a parenting skills simulation. Another one is Talk They Hear You. That is something that SAMHSA actually produced, and it's around underage drinking, and it's meant for parents to use with their kids. Another one, Change Talk, would be something that clinical professionals in your community could use to talk about childhood obesity with parents and patients. Another one is available for Head Start centers. It's actually publicly available, and it has to do with family engagement and educator skills. The one that we just demonstrated, At Risk for High School Educators, is available. It's on mental health and suicide prevention. This link would take you to the launch page for that, and you need an enrollment key, OFA teacher. That is, the availability of that is sponsored through the Indian Country Child Trauma Center, which is the Training and Technical Assistance Center for OJJDP tribal grantees. Similarly, Friend to Friend, which is for high school students, and the enrollment key is there. So those are several hours of education that would be made available at no cost to users across Indian country. In addition, there's a number of simulations that are available for subscription. Other K-12 educator trainings for institutions of higher ed, for veteran families and peers. SBIRT, which if you don't know is Screening, Brief Intervention, and Referral to Treatment. Also mental health, suicide prevention, and substance abuse simulations for use in primary care and emergency departments. And our whole portfolio is available online to review. In addition, any of these simulations can be tailored for more specific cultural adaptations. As Jami mentioned, the work that from the study that she and Glenn did was in non-adapted simulations. The one that she did, the use of the simulation in the tribal community, was also a non-adapted simulation. But there is, as Glenn mentioned, the opportunity to adapt simulations, adapt the characters, the scenarios, the settings, the topics to a Native American population. And those adaptations take about 6 months. We as Kognito bring the technology platform and the learning methodology expertise, and our partners bring content knowledge, subject matter expertise, bring end user input and feedback. It's really, for those of you who do research, it's really community-based participatory research with local communities that can be done. And now I want to quickly just run through a little bit in a tiny bit more detail, and this will be like a carousel practically, but freely available. Again, Talk They Hear You for underage drinking, the parenting skills from Robert Wood Johnson, Calm Parents, Healthy Kids. In K-12 settings, you have the Head Start program. It's actually pre-K-12 that's freely available. At Risk for High School Educators, the one that we just demonstrated, and Friend to Friend, which is peer support for high school students, all freely available, and you should feel free to take advantage of those. Some of the ones that can be added for a subscription cost are At Risk for middle school educators and its companion for elementary school. Step and Speak Up, which is professional development around LGBTQ anti-bullying, which we know is a problem in many settings. There's several for higher education, LGBTQ on campus for faculty, and another one for students. Mental health training also for students and again for faculty and staff, and veterans on campus as well. And last, in the healthcare setting, improving provider antibiotic conversations. That might be something that clinics want to use. Again, the training around childhood obesity, these are freely available. At a subscription cost, it would be At Risk in primary care. So how do you get primary care practitioners involved in collaborating on mental health? Similarly, At Risk in the ED, how do you get emergency departments engaged in substance use and mental health? And for those of you who are working in a zero suicide context, those could be very helpful and important simulations. Also, SBIRT, Screening, Brief Intervention, Referral to Treatment, both with adolescents as well as with adults. And I think we have and congestive heart failure and diabetes. We have patient education modules that really, when you're working in geographically dispersed communities If you have access to computers, these can be used very, very effectively with patients. Practice exposure therapy is something that's available for mental health professionals and delivers 6 APA credits. A couple for veterans and military that aren't for higher education. One is for Family of Heroes, which deals with PTSD and resilience of family members, and a companion for peers. And that's a very, very quick run-through of all of the things that might be of interest to folks out there who are working on health and wellness in Indian country. I hope that some of you will take an opportunity to get in touch with us and learn more. Again, we'll be sure to send out a cheat sheet for things that are free so that you can go ahead and access those and make use of them if they work for you with your priorities. And now we have time for questions. And I hope that you have some questions to ask Jami and Glenn or myself. And Jami, while people are thinking about what they might want to ask, maybe you want to have some thoughts to share.
Yeah, I just wanted to make sure that folks knew, I used to work at the national level with a lot of the Meth and Suicide Prevention Initiative grantees providing training and technical assistance, which is an initiative funded by the Indian Health Service. And one of the challenges that we faced, and this is really what got Glenn and I working together in the first place, was that every time they would get a new coordinator or director trained in the MSPI, there would be turnover that would occur, and the training needs and retraining needs were just so incredibly costly, time-consuming. They were training folks on, training the facilitators for other gatekeeper training programs like Question, Persuade, Refer, QPR, as well as Assist and some of the other models. And once they got someone trained, if that person wasn't committed to staying in the community or something happened and then they took another position, then you really lost that human resource, and it was, again, incredibly frustrating and time-consuming. So this really helps in terms of addressing that turnover, and that once it's available, you can train as many people 24/7. So I feel like that was a real advantage to it. The other thing is that this goes a little beyond other gatekeeper training programs in that it builds in motivational interviewing. So for those of you who know motivational interviewing, it's really a gold standard as a tool to support people in motivating them to make some kind of change in their life. Originally, motivational interviewing was used to support people to stop or reduce substance use and drinking and other negative behaviors. But since that time, it's been used to help people make a lot of change in their life, whether that be diet, exercise, getting help, which is what this one focuses on. And so I think that added motivational interviewing piece, and that you get to actually practice your skills around it, really kind of makes it a little different than what some of the other gatekeeper training programs do. Now, we haven't at this point done any research to compare, looking at comparative research, looking at using this simulation as compared to other gatekeeper training models, so we can't talk about whether or not this is more or less effective, but I think the motivational interviewing piece is definitely a highlight.
Thanks, Jami. And I think that, just to add to what you said, I think that the response that we get when we've looked at user feedback is very telling. I work mostly on the education side and the K-12 side, and I have to say the overwhelmingly positive response we get from educators, I think, is non-trivial in terms of what we would expect from to support results. And I want to say I had a conversation with a superintendent from Illinois today whose schools had participated in our simulations 2 years ago when they were made freely available by the Illinois Department of Public Health, and he was coming back to, and we're working on licensing with him because he said, what was so important on the one hand was you couldn't just click through the simulation and just let it run. If they have mandated trainings, and what they're using right now is a computer-generated voice and that narrates PowerPoint slides. And he said this is just not the topic for that. The other thing he said was the stories and the experience generated a very were the catalyst for very generative discussions in the community around the topic of mental health and suicide prevention in the school. And I think that those things are not something that you see with other similar training. So I would put that out there. We do have a question coming in about our support for community implementation. And what I'll say on the Kognito side, we have a lot of experience helping our clients and partners in schools and other communities do implementation. Our experience in implementing in Indian country is much, much more limited, although if I look at some of our statewide projects, there certainly has been utilization in communities with high AIAN populations. But we have been looking at what are some barriers to utilization and some support for utilization. Some of it is viral, people talking to each other, and I think that once you have some successes, those successes tend to breed more of them. So with Jami's pilot, I think that's indicative of an example that we can now highlight to ensure that more similar communities know about these tools. Jami, do you want to add to that? Jami?
Oh, sorry, there I was on mute. Yeah, no, I think that the one of the things that I felt was the most useful is all the resources that you all have put together. So there's a wide range of resources that communities can access. Some of them are to help educate people about what the simulations are. They include things like flyers and informational sheets and other things. So that would help you. Let's say that you were at a tribal school and you wanted to see about rolling this out, maybe the high school educator one and the friend-to-friend, which you could do in a high school setting. You needed to educate your superintendent to get them to buy off or sign off on allowing the implementation to occur. They've got resources available for that. And that helps. And then also educating parents in the community, too, about what the simulations are and why it's important to participate in that. So I felt like the resources that you all have developed have been really useful. And I don't know if we've talked about those resources or if there's like a link to a site that people can access those, but I find those to be quite useful for implementation.
Great. Well, thank you. Yeah, and we do try to make it as turnkey as possible, as easy as possible for folks to disseminate the training. One thing we didn't talk about also was the other support materials, for example, tracking reports and assessment that are available. So if users are grant funded, for example, and they have a lot of reporting requirements, or they're trying to ensure that everyone in their community has used the tools, we do have the ability to make that transparent to the implementer. There is a question here about adaptation. Have we created Native American characters for these simulations? The answer to that is yes. Very early on when we developed our emergency department simulation, that's going back to I think 2010 or 11, We have a character because we developed that with the Arizona Department of Health Services. We have Lucy Begay, who is a postpartum female in her 30s who is looking for prescription medication in the emergency department. We have to figure out in that simulation whether or not she might be suicidal. We have Mrs. Yazzie, who is the biology teacher in our Step and Speak Up program, anti-bullying. And we have recently started working with the Indian Country Child Trauma Center on a fully culturally adapted simulation for law enforcement professionals that will be released later this year, where we have a whole cast of characters that are Native American. I think somebody wants to know, and I will repeat this, we talked about it at the top of this of the session about slides and recordings, which will be made available to folks after we close. And as always, there's a question about cost. The rule about cost for the simulations is if you are purchasing something that's not already freely available, the pricing favors volume, so the bigger the pool of users, the lower the cost per user. We work with a lot of folks who are grantees, grant-funded programs through SAMHSA and other kinds of grants. And we're happy to create quotes for you, no matter how large or small the community you're trying to serve may be. We're happy to take your calls about things that are free or things that have a cost associated with them, or things that you're thinking about that you really need. As Jami mentioned, you need a solution that maybe is something we don't have, or something that you would like to adapt for specific use in Indian country that is made for general population. We are welcoming all of those inquiries. And we're coming up on 45 minutes for this event, so I'm going to let Jami have the last word.
Oh, thanks. I was just thinking, for me, on a personal note, I'm enrolled Salaki Cherokee Nation in Oklahoma, and, these issues are very near and dear to my community, like they are for many, in terms of making sure that our kids are getting help that they need. So I've actually been giving the simulation out to all of the kids in my family, and interestingly enough, even though he's much younger than what the simulation called for with the friend-to-friend, my 10-year-old nephew actually took the friend-to-friend, which was really developed for teenagers, and I tried to sit with him while he was going through it, and finally he turned to me, he said, "Auntie, I got this." I'm like, all right, cool. So he literally took over the simulation, and when it was over, he came to me and we had a discussion about, what did you learn? And I was just really impressed by how this young 10-year-old was able to talk to me about principles of motivational interviewing and what he felt like he could do to help a friend or even a family member that he might be concerned about, that he wanted to help them get some help. So, I'm really happy that we have several simulations that are freely available to the tribal communities, and I really hope that everybody takes advantage at least of the free trainings that are out there. They are out there and available and accessible, so please feel free to reach out to us if you want additional information. Thank you.
And thanks to everybody for taking the time, and thank you, Jami, for being with us. Thanks to Glenn, and that's it for us today. So thank you all very much.